All right, so we'll do this real quick and then we'll have practice time and then we'll practice, I guess, until you guys have to do cleanup because you guys were bad students. Ultrasound gets messy, right? Okay, so vascular access, I had to take some of the stuff out. I've made some jokes about that were inappropriate, so I'm surprised. That's probably why I'm getting fired on February 28th. Anyway, again, which probe would we use for vascular access? Linear, like the superficial one. And usually we're going to go still have the probe marker to the patient's right or up, unless we're standing at the head of the patient facing their feet, in which we want the probe marker opposite. We want it to our right. So not to confuse you, but when you're doing vascular access, just like a IV, you still want to have the probe marker to the patient's right, okay? So steps for success, you want to do a quick pre-scan before you actually get going. You want to make sure you have your patient positioned correctly, have your equipment, all that stuff set out. And then you're actually going to puncture the skin with the needle, just the skin, the epidermis and dermis, and then use your ultrasound for real-time guidance for the actual IV. So your pre-scan. This is important. We kind of made this complicated, but this says indicator to the left. That's not to try to confuse you. That's because you're facing the patient, but it doesn't matter. You'll be able to see it in real time. But anyway, usually we'll do a linear probe, and you'll do a vascular or venous setting, depending on the machine. They call it different things, but anything vascular should work. You can do it in procedure mode, that's okay. And then on all these little probes, there's like an actual marker here. There's like that shows you where the midpoint of the probe is, and that's where you're going to actually aim your needle for, right at that midline, so that you know that your needle and everything is going to be centered on your screen. Okay, so this is bad grip. So you don't want to hold it like all mousy at the top. This is all bad. It just isn't the correct one. So I'm going to show you the good grip is where you're bracing yourself. You have the Kung Fu grip on the probe, and you're actually bracing yourself. And then you have your dominant hand with the needle in it, whichever gauge you're using. And then you want to have your ultrasound in line with the IV. So if you can see the arm, the screen, the patient all in one view is ideal. And you still put a tourniquet on. Some people forget, like, oh, I'm doing an IV. You still need to put a tourniquet on the patient's arm. And just a reminder of the anatomy, which you already know, but usually which vessel are we aiming for a peripheral IV? Yeah, we usually go like median cubital. What else do we do? Okay, yeah, or cephalic vessel. Those are usually the ones. You can go up higher, you can go lower, like the little intern's vein, but we try to stay away from anything that where there's nerve or artery. Just so you know, in this area here, a lot of people's artery is really close or right adjacent to their vein. So you can hit their artery, so it's just better to visualize and make sure you have an approach that you're not going to actually hit it. Okay, so we're going to identify a vein, and how do we know it's a vein? Because it collapses. I'm going to do some downward pressure with our probe, just like we do for our DVT study. So this is a right arm. We see artery and vein right next to each other. And again, what's this structure up here that has like a little fat pad around it? That's a nerve, right? So I don't want to go in this plane right through the nerve, or this plane right through the artery into the vein, right? So I'm going to have to kind of pregame this a little bit and make sure my approach avoids those structures now that I'm aware of them. Before I was ignorant, now I'm aware that I can see them and I have to avoid them now. The vein again should totally collapse. So we know that the ideal vessel is straight shot with your needle. It's superficial, you're not going to go for a deeper one if you don't have to. It needs to be collapsible, and we're going to stay away from any kind of adjacent important structures. And then we can do Doppler on there just to make sure, but remember, Doppler doesn't tell you if there's an artery or vein, it just says if that fluid or that vascular structure, the fluid is coming towards or away from the probe. So these are our interns, our second year EM residents. They thought they were cool. They took pictures. I mean, I have to say, he always has perfect hair. So he was a perfect model for these, but he's in distress, as you can see. And so they're trying to show you this is a bad position. You don't want to have, you're facing this way with your patient and looking over your shoulder at the ultrasound machine. That doesn't make sense, right? That doesn't seem comfortable. Also, this guy's like 6 foot tall, and in this case, he's squatting next to the bed. They're trying to do everything wrong. Okay, this is like not what not to do. Okay, I think you try to point at his perfect hair. But anyway, this is not what to do. And then once I get through all these, This is a little better. He adjusted the height of the bed to be more appropriate towards him, and then he moved his ultrasound machine around so he could actually have everything in one side. Sounds like common sense, but believe it or not, especially when we're first starting this, we're just so happy with ourselves. We get the right probe and the right settings, you know, and so it's little things that'll make your life easier. So a lot of arrows. We're very proud of the positioning. Okay, equipment. What kind of stuff do we need to have for an IV, whether it's a central line or a peripheral IV? What's that? Yeah, I mean, you need a peripheral IV kit, you need a patient, you need all this stuff, right? Okay, so we're gonna prepare it all. So we need our little flush to confirm. We do need lubricant or gel for the probe itself, and if you're concerned about squirting dirty gel that's been sitting in the container, you can actually use these little Surgilubes that we do for like hemocult tests. They're in the package, they're still sterile in the package, so you can put some of that onto the probe and it would be clean. We need our IV catheter, a little tegaderm to secure it, and either some sort of extension set or either needle or needleless attachment, right? Okay. And then we need gel. Sometimes, well, always, unless it's an emergency, like the patient died, when we do a central line, we do it all in sterile conditions, which is why I'm going to skip over a lot of this, because a lot of this is aimed at teaching people how to do central lines, but I didn't want to keep that information from you so that at phase 2 you can refer back to this and actually, in case you get the opportunity to do a central line. But we need a little bit of sterile gel on the probe, so more than this, so like this is a little bit. And then we are going to put a sterile probe cover if we have to do a central line. And there's actually, you open it up, you're sterile, you kind of put it down the over the transducer, and then you secure it with the sterile rubber bands that comes in the kit. That's only for central line placement. For peripheral IV, we don't need any of that. It's not sterile, we just wipe it with alcohol or one of those little other pads, and that's all we got. So this is sterile, just showing you how you do the sterile procedure if you do the central line, which is why I'm going through this super quick. Just some pearls if you do have to do it, just like if we put a tegaderm over the eye for the ocular ultrasound, you want to get all the air out as much as possible. So if you are putting a sterile transducer cover over the transducer, you want to try to get all the air out, and then you also have to put sterile gel on top of the cover. So you got sterile gel underneath the cover and also on top, so it's double moved, and that's important. And then at least a 2-inch catheter. You need a longer catheter in order for your ultrasound to actually work for you. So who here's done peripheral IV access using ultrasound? Quite a few people. Do you have a specific technique that you like? There's 2 major techniques. There's long axis or the leapfrog. Which one do you guys prefer? You look at the long axis, so you actually watch the needle going into the vein the whole time. Anybody else like something else? Is that what you guys do as well?
I've only done it once, and it was, hey, try this out real quick.
That's cool. That's how it's going to go next Friday after your ultrasound. Don't we have an IV lab afterwards? Somehow I'm double tapped for our ultrasound, and we also have IV lab, and usually we'll have the ultrasound machine set up so you guys can do IV sticks with the ultrasound if you'd like. So anyway, you need a longer catheter, and what I mean by 2 techniques is we can look at the vessel and actually see it, and it looks nice and long. I'm going to show it to you in just a moment, and you can actually watch the needle in real time go into the vessel. You're still going to do a regular IV like you would a normal IV, and I appreciate that for some of you haven't had that instruction yet, but you're going to get it next week. And so what we'll do is you usually have your needle at 45 degrees as you're aiming towards that vessel. You have the tourniquet on, you've already wiped it all off, you got it nice and clean. You're going to put your ultrasound probe over the vessel, and you're going to aim the tip of your needle, bevel up, right towards the midline of that probe, that marker. And you're going to watch it in real time on the screen. So once you get just the tip into the skin, okay, then you're going to start kind of canting your probe and decide which technique you're doing, whether it's the long view, real time, or I prefer the leapfrog technique. You can do whatever you want. So I'll show you what that means. So long axis means that we have the ultrasound probe in line with the vessel, and the vessel looks long like this. So when we're putting the needle in, you can actually see it come in and actually go through the vessel, and it's a really good view so that you can see that you don't go through the vessel on the other side. So I'll show you that little video one more time. So we're kind of coming in at an angle, and you can see it in real time. And then once you see it puncture through the vessel, you should look down and you should see a flash of blood in your catheter. At that time, your ultrasound part is over, right? You don't need it. You can set your ultrasound probe down, thread your catheter, take out your needle, secure it, and do all the other things. that's what a lot of people do, and that's perfectly fine. There's some challenges to this long axis approach. So if you have your, if you're straight up on the vessel, you can actually, or if it's canted a certain way, you can actually go right through it and not see the other tip of your needle because you're actually blocking yourself. So it's important that we kind of keep our, even though we're in long axis, we kind of keep the ultrasound probe canted just a little bit. And we can practice this if you'd like, but this isn't what you're tested on. Short axis approach is what I personally prefer. I'm going to go through this pretty quickly, and it's where you do a leapfrog technique. So what you do is you identify the vessel. It just looks like a round structure, just like we've been doing with DVT. That's a short axis, right? It just looks like a round circle, and we're squishing it. Okay, that's how I prefer. I identify it. I start entering the needle into the skin, and then you actually have to leapfrog, like move your ultrasound probe a little bit, and then move your needle a little bit, move your probe a little bit, move your needle a little bit, which is why it's called a leapfrog technique. And so I tried to reproduce this on a cartoon. It took me like hours of my life that I'll never get back, but your viewing pleasure here. So this is what it does. So I'm gonna go back. So I've got the ultrasound probe. I identified where the vessel is, but now I've got the probe canted a little bit so I can see the tip of my needle, just the bevel. I don't want to see the shaft, just literally the tip of the needle, okay? And there's all kinds of jokes I'm just staying away from because I still want to be employed for a week. Okay, so we've got the little, the bevel there. We can see this, okay? We're going to go a little bit further. Now I'm going to leapfrog my probe and then advance my needle just a little bit. Like we're talking millimeters at a time, not inches, just millimeter at a time. We're leapfrogging it in until I can see it. And this is what it looks like in real time. So you'll start seeing a shiny thing at the top. That's your tip of your needle. And they're going to move their probe. They're going to watch their needle tip continue down. They're moving their probe, leapfrogging it, keeping the vessel centered and in line the whole time. Eventually you'll start seeing it as the tip of the needle gets closer to the vessel. And right as you are about to puncture into the vessel, you can start seeing it kind of collapse from the weight of the tip of the needle. And then you saw the tip right there. It's in. So I prefer that technique. It's just because that's the one I learned. It might seem a little more like you need more dexterity to do that. So whichever technique you want, try both. It's a fun thing to do. Okay, this is where I just think this lecture gets a little awry. And in my own defense, they took 4 hours out of my block of instruction. So we're supposed to have a 4-hour extra lab. So that's why I'm kind of rushing through the things that won't matter for your test out, but want to introduce you to it so that you can perfect it later. And then if you're interested in this, we can practice. I have these little things that I'll set out so that while you're waiting your turn on the machines, I'll try to set up some butterflies if I can get them to work, and you guys can do some ID stuff while you're waiting, especially for Monday. Okay? Any questions about these? Okay? All right, so you guys want to break into our groups and start practicing? Let's do this. Let's get